the optic nerve, optic chiasm, lateral geniculate bodies, optic radiation, visual cortex, cortical areas make up the visual pathway. And this entire pathway may be regarded as a part of the central nervous system. And during development, it has extended forward into the orbital cavities of the skull. So this is the point of view on the visual system as a part of the central nervous system. You know that the adequate irritant of the photoreceptive apparatus of our retina, of our eye, is light. Light is a visible portion of electromagnetic radiation spectrum, and it lies between, as you will see in next slide, it lies between ultraviolet and infrared portions, from 380 nanometers at the violet end of the spectrum to 670 nanometers at the red end. The neuronal component of the retina consists of two types of photoreceptors, and I hope that you remember from the basic disciplines the name of these two types of photoreceptors. They are the rods and the cones. And they can transduce light signals into electric impulses, which are amplified and integrated through involving bipolar, horizontal, amacrine, and ganglion cells, and transmitted through the nerve fibers layer to the optic nerve. So here you see the anatomy of two types of photoreceptors, rods and cones. The rods and cones serve as sensory nerve endings for visual sensation. Light falling upon the retina causes two essential reactions: photochemical and electrical. Photochemical changes in the rod pigment, and we name it rhodopsin or visual purple, are fully elucidated, while those in cone pigments are not yet fully understood. We don't know exactly the basic principles of color formation. So probably cone pigment react but preferentially to different bands of wavelength, or there exist different types of cones which are responsible for different types of colors. The photochemical reaction initiates the visual sensation in the form of changes in electrical potential, which are transmitted through the bipolar cells to the ganglion cells, and then along the fibers of the optic nerve to the brain. The rods are mainly responsible for vision in dim light, the so-called scotopic vision. Greek word scotos means darkness, and produce images consisting of different shades of black and white, while the cone called photopic vision, photos, Greek word, one more Greek word which we use in our practice, photos means light. So photopic vision is the result of the activity of the cones. And also cones can resolve fine details, and also cones are responsible for color vision. So you see that there exists a difference in function of two types of photoreceptors. Rods, one more time, are responsible for vision in dim light and for peripheral vision. Cones are responsible for central vision, for vision in case of bright light, the so-called photopic vision, and also cones are responsible for color vision. With the help of rods, we can see only in achromatic type of vision, means we can see only black, white, and different tones of gray. With the help of cones, we can differentiate between different colors. It's necessary to know the principles of the anatomy and functioning of two these types of photoreceptors, because if you know the function and if you know the anatomy and the geography, the localization in the retina, you can understand or even suppose the main clinical symptoms of different types of disorders which damage different parts of the retina. I mean, due to the presence or absence in these areas of different type of photoreceptors. So the density of the rods and cones varies in different parts of the retina. The rods are absent at the fovea, rising rapidly in number towards the periphery. The cones, on the other hand, are most dense at the fovea, and the numbers decrease at the periphery. So you can understand clearly if there existed damage of the central part of the retina, where exist a lot of cones but a small amount of rods. The main problems will be problems or main complaints of the patient will be on the poor vision for far, for the central vision, maybe absence of central vision in form of dark spot in front of the patient eye, and problem with the color perception. In case of peripheral retinal damage, we can see usually the problem with the peripheral vision, constriction of the visual field and so on, and problem with the vision in dim light, the so-called problem with the so-called scotopic vision. So patient has a sort of dark blindness when in dim light he has a poor vision, but in bright light his vision is rather good, normal or subnormal. So several words about the visual perception. It is a complex integration of light sense, form sense, sense of contrast, and color sense. The light sense, it's the so-called, we can name it as, we can describe it as an awareness of the light. The minimum brightness required to evoke a sensation of light is called the light minimum. It should be measured when the eye is dark adopted for at least 20-30 minutes. If you have to check patients' light adaptation and try to find patient's light minimum and compare with the normal result, you should leave the patient in the dark room for 20-30 minutes, and after such a total dark adaptation, you should switch on the illumination on the special screen from the very beginning. And at the moment when the patient will see the light, it will be the patient's light minimum. In case of several disorders, the light minimum is change its result, and we can understand that this is the sign of the damage of the visual pathway of the retina, of the different elements of the retina, and make a conclusion. It's like an additional examination to check and to put the correct diagnosis. Sense of contrast. Before we continue about the sense of contrast, several words about the so-called dark adaptation. It is an ability of the eye to adapt itself to decreasing illumination. When one goes from bright sunshine into a dimly lit room, one cannot perceive the object in this room until some time has elapsed. So during this period, eye is adapting to low illumination. and the time taken to see in dim illumination is called dark adaptation time. Normally, dark adaptation time is about 50-60 minutes, about 1 hour or a bit less. Of course, this is the maximum of dark adaptation. The first objects patient can see in a dark room after several seconds, but when the dark adaptation will start. But the maximum adaptation and the highest ability to differentiate between different objects is after about 1 hour. So this is the normal dark adaptation time. In case of several disorders, this time uh, may be increased and also be a symptom of several disorders. Light adaptation, it's on the other hand, it's an ability to discriminate between the shapes of the objects. Cones play a major role in this facility, and form sense is most acute at the fovea. There are maximum where there exists a maximum number of cones. And sense of contrast, one more function, visual function of our visual system. It is ability of the eye to perceive slight changes in the luminance between regions which are not separated by definite border. So all these functions may be measured by special equipment, and according to the results of these tests, we can make a conclusion about the activity, about the normal or abnormal situation with the visual pathway, with the retina, with the optic nerve, and with the other elements of the visual pathway. Several words about the clinical picture, clinical features of several disorders which are associated with the changes in such visual functions like light adaptation, dark adaptation, like visual perception, and so on. One of the most frequent type of the visual perception changes are the so-called different types of night blindness. We use a lot of Greek words in our practice, so name of this disorder is nyctalopia. Optos means eye or vision, and nyctos means night. So night blindness, as we know already, the night or scotopic vision is a function of rods. Therefore, the conditions in which functioning of these nerve ganglions is deranged will result in night blindness. Now, this includes vitamin A deficiency, different types of hereditary degenerations, the so-called tapetor-retinal degenerations of the retina, congenital high myopia, familial congenital night blindness, and in advanced cases of primary angle glaucoma, dark adaptation may be so much delayed that patient gives history of night blindness. So what is the clinical picture of night blindness? The main patient complaint is poor vision in dim light. But at the same moment, patient may have the normal visual acuity in bright light. So these are the result of the difference in function of two main types of photoreceptors, and all the changes of the rods of the peripheral retina, where the most amount of rods, may cause such a clinical picture. It's really difficult to treat such condition because in most of types of night blindness, changes of the retina are irreversible. When we're talking about the different types of degenerations, acquired or congenital, in advanced stage of high myopia, complicated myopia, or open angle glaucoma. Unfortunately, usually it's irreversible situations, and we can't increase. We can just try to stop the progress of the disorder with the help of different types of drugs. Maybe in future we'll have in our practice such drugs as drugs for gene therapy to correct the different types of congenital dystrophies, congenital degeneration, and now we can see the first attempts to do it, but they are not successful in all the cases, and the price for such drugs, which we should implant under the retina or in the retina during the very complex vitreoretinal surgery, the price is very high. They're very expensive. But we hope that in future, with the development of the new technologies, we'll get such a possibility, because sometimes the severity of night blindness and other symptoms of which are associated with these types of dystrophies are so high, so severe that they really damage the patient's quality of life, and some of these patients are really disabled person. Uh, Another situation, another type of disorders are different types of day blindness or hemarlopia. It is a symptomatic, usually symptomatic, not organic disturbance of the vision in which the patient is able to see uh, better in dim light as compared to bright light of the day. Its causes are congenital deficiency of cones, central lenticular opacities, for example, polar cataract, and central corneal opacities. Uh, the main question, how is it possible if the patient has poor vision in bright light when there good illumination, luminance, but poor vision in dim light, in good vision in dim light? For example, as you remember, I hope, from the physiology, normal physiology, from the anatomy, our pupil hole in the center of the iris can change its size, the so-called pupillary reaction, as a result of presence or absence of light or amount of light rays. And in bright light, there exists constriction of our pupil. In dim light, dilation of our pupils are very wide. If you have any opacities opposite the pupil, opacities of the cornea, opacities of the crystalline lens, of the vitreous body, and in bright light it will be constriction of the pupil, and this opacity will be just opposite the pupil, and there will be no possibility for the light rays to pass through this opacity and to get retina normally. Vision will be decreased, will be rather poor. On the other hand, in dim light, there exists a dilation of our pupil, and the light can pass, come, can get the retina through the peripheral part of the crystal lens, of the cornea, of the vitreous body, uh, without any problems, because the opacity is in the central part. And in this case, patient will say, yes, I have a better vision in dim light after the pupil dilation compared to the bright light. In this case, it's more easy to help such patients because we can treat these opacities of the cornea, opacities of the crystal lens by surgery, different types of ophthalmic surgery. We can extract cataract and implant artificial crystalline lens. We can perform keratoplasty, or the so-called corneal transplantation, and so on. And most of the disorders which we compose in day blindness, they are functional. And after excluding the main problem, patients visual in bright light recover to the normal condition. And in case of the night blindness, we have no such possibilities, and most of cases of night blindness are unfortunately irreversible up to date. The next topic for discussion is the so-called visual acuity. Of course, you know this term, and if you see the picture, you understand that you have already performed this practical skill, maybe not as a doctor, but as a patient, because in all the countries, in all the parts of the world, method of visual acuity examination is the basic method in ophthalmology for testing of the visual functions. For all the patients who will come to the ophthalmologist, it's necessary to check visual acuity. What does mean visual acuity? It's a retinal function, first of all, to be more precise, of the macular area or the so-called yellow spot of the retina. Visual acuity should be tested, as I said before, in all cases, as it may be affected in numerous ocular disorders. Visual acuity is the ability of the eye to see two distant points as separate. The chart most commonly used for distance vision with literate patients is the Snellen chart. Principles are the same in different countries of the world. The difference only in letters due to the alphabet which is used in this or that country. For patients who can't speak, for example, or for illiterate persons, we can use another types of charts consist of different symbols, like here, like in form of letter E, in form of ring with a break. In this case, task for the patient to recognize where is the break or to the direction of the letter E, position, and so on and so forth. For the small children, we use special charts consist of symbols which the small child can rather easy describe, like flower, mushroom, sun, cat, and so on and so forth. So the symbols, the so-called optotypes, are different, but the principles of these charts are the same. Distance for the examination is also different in different countries. For example, in our country and during our practical classes, we will use the distance 5 meters. In most of European countries, it's 6 meters, but the formula is the same. So if you'll check a patient with the same chart in different conditions and use the correct formula, the result will be the same and it's not associated with the distance. The so-called Snellen formula, which we use, where visual acuity is equal to small d by large D, where small d, distance from which the patient, your patient, can read the letters of one of the lines, and large d, distance from which the normal eye can read the letters of the same line. Usually on the Snellen charts, you can find the large D for every line, normal distance from which the normal eye can see, can read and can recognize these symbols of this line. So task for the doctor in this case just to measure the distance from which the patient can recognize this letter, and with the help of this formula count the result. But if you are in a fixed on a patient is on a fixed distance, for example, 5 meters, your task is just to check different lines until the moment when the patient will say, no, I can't see the next line. And according to the last line which the patient can read from the definite distance, you can make a conclusion about the patient's visual acuity. And of course, this result in all the case should be written into the case history, and we can use this method for the diagnosis at the stage of the diagnosis, so the first diagnosis, and as a parameter uh, which can be changed, which can be improved and increased by our treatment. And so in this case, it will be a sort of dynamic parameter which we use to understand and to determine the efficacy of our treatment. There exist several objective ways of visual acuity testing by Optokinetic Nystagmus, which help us to determine several rather specific situations in our real practice. Maybe you know such terms as simulation and aggravation. There exists a group of patients who try to show results of the examination a bit worse than they really have. They try to increase the symptoms of their disorders. Now, if the patient uh, want to become a disabled person, I mean on the paper, because you know that in most of the countries there exist special programs, government programs for the disabled persons, and they can't work and they just get money from the government because they're a disabled person. So it's one way. On the other hand, we have patients who has real problems with their visual functions. They have severe myopia, other disorders, but they try to show results a bit better than they really have. No, for example, patients want to be a pilot or a driver, but his poor vision is a contraindication for such a condition. In this case, patient tried to show results a bit better to get this job. Maybe it's his dream of his life. But of course, it's if there exists any contraindication, you should find them. If you have any suggestion about the or suspicion that patient is not correct in his answers, because this method of examination, I mean visual acuity examination, is based on the patient answers. You show the patient will say, yes, I see, or I can't see, and name the letter. So if the patient won't, he can say, no, I can't see, but he can really see it. Or on the other hand, the patient try to remember the letters before they visiting the doctor and then try to show the results a bit better. So if you have any suggestion, you can understand it during the examination. If you find any pathology and you understand that in case of this pathology, this vision can't be so perfect. So in this case, we can use this specific method based on optokinetic nystagmus. I hope you remember also from physiology, what does mean nystagmus? It's a spontaneous oscillatory movement of the eye. When we look at the moving object, our spontaneous. In this case, we use the same method. The patient sit in front of the screen, and you'll see that when you'll see the patient is ready, you begin the test, you'll see that there exists a moving of the object in front of the patient eye. And if the patient can see these lines, you'll see optokinetic nystagmus. If the patient can't see, there will be no changes of the position of his eyes. And patient told you can tell you about his visual functions, but if you see the nystagmus, for the patient I can't see, but if you see the nystagmus, it means that patient really can see it, these lines. And you can change the amount of lines, you can change the speed of the lines, you can change the size of the lines, the distance from the patient to the screen. So, and with the help of the same formula, Snellen's formula, you can you can count the correct visual acuity and make a conclusion about the patient's visual functions and about patient's behavior also. So it's very important because if you sign the result, and if it will be mistake in your result and there will be any accident with this patient because of his poor or good vision, of course it will be not only patient's problem but also doctor's problem. So the next visual functions, very important visual functions, the so-called visual field. Visual field is the three-dimensional area that can be seen around the object of fixation. What does it mean? If you fix any object in front of you, with your peripheral vision you can see also, not so clearly, but you can see another object, any movements when you cross the road. It's no need for you to turn your head all the times. With your peripheral vision you will see any dangerous and stop. This the extent of normal visual field you can see here in scheme, this black line. This is the normal visual field of the patient, of his right and left eye. So the extent of normal visual field is superiorly 55 degrees, inferiorly 60 degrees, nasally 60, and temporally 90 degrees. The procedure for estimating the extent of visual field is called perimetry. One more Greek word. Peri means around, metros means measurement. So examination of the surrounded world, of the surrounded field of vision. This is perimetry. There exist several types of perimetry. One of the most frequent type which we use in our practice is kinetic perimetry. Kinetic means that the point of the object by which we test the visual field moves from the periphery usually to the center. So this stimulus is moved to establish the visual field in different meridians: superior, inferior border, nasal, temporal borders, and four oblique meridians: superior temporal, superior nasal, inferior temporal, inferior nasal. Various methods of kinetic perimetry are confrontation method, which we will train during our practical classes, Goldman's perimetry, Lister's perimetry, and so on and so forth. There exist different types of kinetic perimetry. Now, of course, we use computer perimeters. Task for the patient to switch the button when he can see the object, and if he can't see, no need to switch. And then the computer will give you the result in form of special schemes, and you can make a conclusion about patient's visual field. Another type of perimetry, which is also very effective and is used widely in all the ophthalmology clinics in all the world, is the so-called static perimetry. This involves presenting a stimulus at a predetermined position for a present duration with varying luminance, uh, like a flashes of different objects in different parts of the patient's visual field. And also patient has a button, and he should switch it when he can see this flash, and according to the presence or absence of stimulus on the scheme, you can make a conclusion about the central patient's vision, sometimes even peripheral vision, and you can also change the intensity of light in different points and make a conclusion not only about the presence or absence of vision in different parts of the retina, but also the um, possibility of the different parts of the retina to discriminate between the different intensity of light. Sometimes the suppression may be not full but partial, and in this case it's necessary to determine the degree of depression of visual functions in different parts of the retina, different points of the retina, to compare with the normal result and to compare this situation before and after treatment. to compare the progress, to check the progress of the disorder, and so on and so forth. So with the help of these methods, especially static perimetry, we can now determine and put the diagnosis in a very early stages of several very severe disorders, for example, glaucoma. Sometimes patient has no complaints, but with the help of special programs, special computer perimetry programs, we can find the very early changes of the patient's visual field, and it will help us to start our treatment as soon as possible and to save the patient's function for a very, very long period of time and to prevent blindness. Various methods of static perimetry are adopted: Goldman perimetry, Friedman perimetry, automated perimetry, and so on and so forth. Here you see one of the computer perimeters, which is widely used in real clinical practice. A very old method of perimetry, the so-called campimetry, is done to evaluate the central and paracentral areas about 30 degrees from the point of fixation of the visual field. We need a black desk, we need the white points, but of course this type of perimetry was used before the era of computer perimeters. Now it's just, I show just a historical moment. And several words about the different types of defects of visual field. And let's start with the so-called scatomas. Remember that the Greek word scatomas, skotos, means darkness. So scatoma, it's a sort of, if we talk about the patient's impression, it's like a black spot or dot in front of his eyes. And the definition of scatoma, scatoma is isolated defect of visual field. Isolated means not connected with the peripheral borders. Patient may have normal peripheral vision, but somewhere in the center, he has absence of visual functions in one or several points. These are scatomas. Causes, the main types of causes of scatoma appearance are disease of the retina, disease of the optic nerve, and glaucoma, advanced stage of glaucoma. They exist in our eye, in all the eyes of all the persons. There exist physiological scatomas, the so-called angioscatomas, due to the presence of the blood vessels on the retina, and there is no visual functions in these areas, where just blood vessels and no rods and cones. And blind spot, one of the main and the most interesting places on the optic nerve disc or on the retina is the optic nerve disc. And in this area there are no rods, no cones, and of course no light perception. It's a very small area, less than 1.5 millimeters on the retina of every eye, and we can't see it without a special examination. We can't determine it, but even during our practical classes, I hope that you will have such a possibility to examine each other, and you'll find this blind spot during the visual testing in all of your group mates. So it's a physiological scatoma, it's not a pathology. And about the pathology of the eye, I mean pathological changes, pathological types of scatomas, we'll discuss in 10 minutes after the small break. So now we have a small break about 10 minutes, and then we'll continue with the different disorders of the visual fields. Well, let's continue our today's talk and let's discuss the different types of disorders of the visual field. Pathological changes. Let's start with the different types of scotomas. So the first type of scatoma is central scatoma. Central means it's like a black spot or dot in the central part of the patient visual field, in the point of fixation. Usually these types of scatomas are associated with the damage of the yellow spot of the macular luther of the retina as a result of the dystrophic changes, traumatic changes, like a complication of several disorders, hemorrhage in this area, and so on and so forth. It may be positive or negative. If your patient has a complaint on a black spot dot in front of his eye, this is the positive central scatoma. If the patient has no complaint, but you find these changes during the specific examination, this is the negative scatoma. No complaints, but presence during the specific tests. So this is central scatoma. It looks like here on the blank of the visual field. The next type of scatoma is the so-called arcuate scatoma in form of arc. It may be in the superior, maybe on in the inferior part of the visual field. And in this case, it's necessary to, if you find such scatoma, it's necessary to exclude such disorders as glaucoma, for example. And it may be one of the early changes of visual field associated with this very severe disorder. The next type of scatoma, the so-called centrocycle scatoma. Cecum, Greek Latin word means blind, so blind spot. If your scatoma, patient scatoma, cover the central part, central point, and the area of the blind spot, which is situated temporally between 12 and 18 degrees of the visual field, in this case, we name this scatoma the so-called centrocycle scatoma. The next type of scatoma, here you see not the type of scatoma, but how does it look like, the scatoma from the patient eye. You see it's like a point, maybe dark, maybe even black, sometimes grayish, whitish, yellowish, depend on the etiology of the process. In front of the patient eye. And of course, patient can't read, have poor vision for far, and have a lot of other problems if he has such a disorders. And it's necessary to determine the reason, the cause of this disorder. And if we have a possibility to uh, treat successfully such a patient and to exclude this scatoma, it will help us to recover the visual functions and to increase the quality of life of the patients. But of course, in a lot of cases, it's very advanced stages of different severe disorders like age-related macular degeneration, like glaucoma, like optic nerve atrophy and other optic nerve changes, and most of them are irreversible. It's really difficult to help a patient in this case. The next large group of visual field disorders, the so-called generalized constriction of the visual field. Also associated with the disease of the optic nerve, also associated with the glaucoma. We can see constriction of the peripheral visual field borders in most or in all the meridians. Sometimes patient has so poor vision that they look to the surrounded world like through the tube, and in this case they are disabled even if they have high visual acuity. It's really difficult for them, for example, to cross the road. Difficult and dangerous. Also, most of the disorders are irreversible. We can just stop the progress, but it's very difficult to improve such a loss of visual field. And the last group of visual field, the so-called Hemianopic defect. Hemi means half, an means absence, Opaque means visual. So hemianopic defect means absence of one half of the visual field. And according to the type of the defect, they exist homonymous and heteronymous hemianopic defects. Heteronymous may be binasal and bitemporal. In several next slides, you will see the examples of such defects. What are the main causes of these disorders? Disease of chiasm area, disease of retrochiasmal parts of the visual pathway. So these are the most frequent types of the etiological factors. Here you see one of the types of these homonymous defects. It's of the hemianopic defects. This is homonymous because both right sides of the visual field are absent. So this patient, if you show him any object, your fingers or any other object in front of his eyes, from the left side, the patient will see it clearly. But if you show them from his right side, patient unfortunately can't recognize because he can't see any object due to the usually retrochiasmal damage of the visual pathway behind the chiasm. So these are usually associated, these types of disorders usually associated with the severe damage of the um, central nervous system. Now you can see heteronymous type of hemianopic defects, and here you see binasal. So patient can't see from the nasal side of every eye, but can see with his peripheral temporal side. And if the patient look with both eyes at the same moment, the so-called binocular vision, he can see periphery from both sides, but can't see the central part in front, just in front of his eyes. This is the damage of the chiasm. And bitemporal side, when the patient can see only the central part of his visual field but can't see to peripheral. This is also damage of the central part of the chiasm because of the, for example, tumor of the hypophysis. And here you see how does it look like binasal in the upper and bitemporal in the inferior pictures. How does it look from the patient eyes? In most of cases, it's not a ophthalmological, but it's a neurological or even neurosurgical problem disorder, and we can just help our colleagues, neurosurgeons, neurologists, to put the correct diagnosis and to localize the area to find the level of the damage of the central nervous system. And then if will help them to find and localize the tumor of the brain and so on. Of course, this patient, they need a specific neurosurgical and neurological treatment. We can just check the eyes from time to time after the surgery, after the successful surgery. And in some of patients, we can see recovering of the visual functions, improving of the visual functions, and not in all, unfortunately, but in the rather large group of patients, we can see a good dynamics of the visual functions, visual field, after the successful treatment of the etiological problems, etiological disorders. And the last but not least for today, the color vision and the color vision disorders. Color vision or color sense, it is the ability of the eye to discriminate between different colors excited by light of different wavelength. It is a function of cones and thus better appreciated in photopic vision. Cones perform this function by three different types of pigments which absorb red, green and blue wavelength of light. So there exist only three primary colors: red, green and blue. And the normal color vision is called trichromatic. One more Greek word: tri means three, chromos means color. So trichromatic vision means the theory of the color vision based on the theory by Helmholtz, uh, that there exist three primary colors: red, green and blue. They have different wavelengths, and there exist different photoreceptors, or the same photoreceptors but different with different specificity, which resorb different wavelengths and react on different colors, three primary colors. All other colors, even white color, it's just a composition of these three primary colors of different wavelengths. All other colors, even white one. This theory was put forward, as I said before, by German von Helmholtz. All other colors are combination of these primary colors in different proportions. In dim light, scotopic vision, all colors are seen as gray. So our rods has no possibility to differentiate between the colors. And if there exists a scotopic vision in dim light, all the object looking gray for us, and it's impossible to determine their real colors. You know it very well. Purpose of color vision testing. It's very important because the demonstration of adequate color vision is mandatory for certain jobs. For example, pilots, drivers, sometimes painters. Job affected are armed services trainees, transportation workers, and so on and so forth. Color vision may be disturbed in early macular diseases, whether toxic or idiopathic degenerations, and in the optic nerve disorders, chiasmal and central nervous system disorders. An individual with normal color vision is known as trichromat. Uh, person who has normal perception of three primary colors. In color blindness, faculty to appreciate one or more primary color is either defective, anomalous perception, or absent, anopia. It may be congenital or acquired. Congenital color blindness is an inherited condition affecting males more than females. About 8% of all the world population, or 8% of males, has a problem with the color vision, with color sense, of different degree. Most of them has problems of very small degree, which is not a contraindication for any activities, any types of job. But of course, there exists a group of persons who can't be pilots or drivers or something like that. And only 0.5% of the females has the same problems. Usually we can see the type of genetic um, scheme from the grandfather to the grandson through the mother. And usually grandfather and grandson has a clinical picture of this problem, but mother of this grandson, daughter of this grandfather, has no clinical signs. Just they have, she has a gene of color blindness, but without its expression, without a clinical picture. Um, so here you see examples of anomalous color perception, which may be protanomalous when we can see anomalous perception of the red color, then deuteranomalous of green color, and tritanomalous of the blue color. Here you can compare the normal picture and picture of the patient. How does it look like? The perception of the anomalous perception of the red color. No, you can compare this red car and how does it look like uh, from in the eyes of the patient with the prot anomaly. And here you see the original picture and picture painted. It's a copy painted by the person with the abnormal perception of the red color. You may compare, for example, here you see the patient in the red tunic, person in the red tunic, not maybe he's not our patient. And here you see how does it look like for the person with the protanomalous. Uh, One more example, due to anomalous. Here you see problem with the green color perception. Uh, One more patient and one more patient who create a copy of the picture of the original picture with the wrong perception of the green color, and the patient with the wrong perception of the blue color, and you can compare the normal condition and how does it look like from the eyes from the patient with the so-called treat anomaly, anomalous perception of the blue color. And here you see patient with the protanopia, total absence of red color perception. In this patient has blindness on a red color. He can't see, can't differentiate red color from another. You can't find in this picture red color at all. Patient with deuteranopia, patient who can't recognize the green color, and anopia, patient who can't recognize the blue color. You can see that there is no blue color. It, it it's like achromatic vision, very severe disorder. Some patients has problem not with one but with two of three primary colors. This condition is called monochromatic vision, when the patient can recognize only one of three primary colors. And the most severe disorder when the patient can't recognize any colors at all except black and white and grayish color. Uh, Different tones of gray color. In this case, but this condition in our population, I mean people's population, among the people, um, in this case, it's usually associated with the severe damage of the vision, and it's usually impossible to determine this condition. But we know that several animals has a achromatic vision as a normal condition. They, for example, wolves, they have no possibility to differentiate between the colors. They have achromatic vision. For the diagnosis, for the tests, we use special charts. Consist of black of spots, dots of different colors, or the same color but different intensity, different tone, which compose figures, usually numbers, like in the left picture, or simple geometrical figures, like in the right superior picture, or right inferior picture, triangles, circles, squares, and so on. Task for the patient to recognize. During the examination, it's necessary to ask the patient to sit opposite the doctor, and it should be natural light during the examination, because artificial light of different lamps of with warm colors or cool colors, they can change the color perception, and maybe it may be a source of mistakes in your diagnosis. So natural light is one of the main conditions on the surface of the book or plates. You show the patient these tests, usually from the distance 1 meter, and the patient should recognize. If your patient can recognize all the charts, all the symbols without any problems, you put that patient has normal color perception, the so-called normal trichromacy. If you'll find any changes, you should analyze, because every plate in these books devoted to the examination of specific color, red, green, and blue, one of three primary colors. And according to the tables which the patient can recognize, you can make a conclusion about the patient's problem. What types of problems? I mean, what kinds of colors of types of photoreceptors, and what colors are damaged in patient's eyes. Because it's very important for understanding not only the patient's problems, but also the diagnosis and the possibility to correct. Of course, the congenital anomalies we can't correct, and we can't help such a patient, unfortunately. In case of acquired pathology, which is usually associated with the disease of the optic nerve of the retina, it's possible to help such a patient by successful treatment of the main disorder, inflammatory disorders of the optic nerve, other types of some vascular changes, and so on and so forth. And after the successful treatment, usually we have no problem with the color vision, with the total recovery of the visual functions. One more difference between the acquired and congenital, that in case of congenital, we can always see the bilateral damage. So both eyes are involved in the pathological process. In case of acquired pathology, it depends on the localization of the inflammation or other types of changes. So it may be unilateral, right or left, or maybe bilateral, but usually unilateral. And one more very important difference, in case of congenital anomalies, we can usually problems only with only two primary colors, red and green, and no changes with the blue color. In case of acquired pathology, we can see a problem with usually all three colors, but the most severe damage of the blue color. So it's necessary to remember when you check the patient eye to determine congenital or acquired type of pathology. That's all for today. Thank you for your attention. If you have any question, we can discuss them now, or you can ask me during the practice and other teachers during the practical classes, or use the chat for discussion. If you have no questions, that's all for today. Thank you for your attention, and hope to see you during our practical classes. Have a good evening and goodbye.
Thank you, sir. Asvidanya.
Good evening, sir.